So the second lecture that has to do with cognitive impairment of the elder adult is actually going to focus on dementia. We're actually going to look at seizures too. So when we start talking about dementia, the one that obviously comes to the forefront is Alzheimer's disease. Dementia in and of itself is actually an umbrella term, and it's a general term. And really, all dementia is a decline in memory and thinking skills that results in the patient not being able to function at all. So it results basically in a functional decline. So majority of these people will have Alzheimer's disease, but there are several other kinds of dementia as well. So each of the dementias is actually based on some sort of physiological process. Also, a recognized protein or a set of proteins has actually been identified with these different disease processes. So for example, in Alzheimer's disease, we're looking for amyloid plaques and these tangles that happen because the synapses get interfered with and will break off. They're very brittle. Notice in frontotemporal dementia, we're looking for tau or different types of proteins. And then the Lewy body or the Parkinson's dementia, there's an accumulation of a different type of protein. So basically this accumulation of protein sets off basically what ends up happening in the disease process and what interferes with the neuronal synapses that happen in the brain, which will cause the decline in the function in the patient. So there are definite risks that go along with dementia, usually elder adults. So as you grow older in age, if you have a family history, so for example, Alzheimer's, unfortunately, there is a genetic component that's associated with that. Depression, people who have Down syndrome, other risks that put you at risk for dementia, we talked about earlier in another lecture about delirium. If you have some sort of head trauma, if you have comorbidities like hypertension, hypercholesteremia, um, and then, unfortunately, there is an environmental factor. For example, if you have a lower educational level and you're not educated on what the disease process could look like, it could worsen, of course, the condition. There have been shown to be some protective things on there, and I'm sure you've heard several of them. Majority of them are antioxidants and some other health or herbal remedies that maybe your family utilizes to help prevent dementia on here as well. When you diagnose dementia, we really don't have a single test. Really, it's looking at a medical history, the worsening of the medical history, the worsening of the physical exam, neurological testing, those kinds of things. So we also rule out other disease processes like delirium, like depression, all of those other things. It's really not due to another physiological or a neurological or psychiatric condition. It's usually actually not related to medications either. Usually it is a physiological process that's happening. So we do need to look at how well people are functioning. So we do have a exam. As we've learned in the other lecture, there we have the geriatric depression scale and the confusion assessment method, which is the CAM. Here, when we're looking at dementia, we're looking really at the functional capability of the neurologic and mental status. And so we call it the mini mental state exam, or the MMSC. And you may have heard of this as well in your psych class. So we also can do actual use of biomarkers and brain imaging, so we can look and find those protein buildups and those protein synapse breaks that are there, like the Lewy bodies and the neurofibrillary tangles that are associated with Alzheimer's disease. So that's what we're going to look for when you're diagnosing your dementia. We're looking for the pattern. You're looking at the pattern of the loss of cognitive decline. You're looking at normal aging impairments like delirium, occasional delirium, which is an acute confusional state, versus dementia, which is a chronic and a digressing confusional state. Mild cognitive impairment is where you see a cognitive decline, which is noticeable but doesn't really impact the independent living. So you might see people who um, might be forgetful, but they still live in a facility of some sort and still live by themselves and are just being watched. But they can do still their own dress, they can feed themselves, those kinds of things. So here's the different types of dementia. You can see dementia is the umbrella term. So you can see under that we have Alzheimer's, which is the most common one we see when we talk about dementia. But notice on here we talked about the Lewy bodies. In all honesty, in the Lewy bodies, we usually don't find the Lewy bodies until the person is basically deceased, and then they look at the brain, and then they'll find the Lewy bodies there. So the Lewy body dementia we really don't diagnosed until basically after the person is deceased. Alzheimer's we can see while the person is still alive, the frontotemporal, the vascular we can find while the person is still living, and we're looking for those deficits of the proteins. The Lewy body dementia is really the only one excluded, as I've been reading and looking at dementia, is the one that you really find after, they'll find those bodies after the person has actually been deceased. But Alzheimer's is the one we're going to focus on here in our class for this quarter. So basically, you're looking at a gradual onset progressive decline of cognitive functioning. And so this is both motor and sensory. So memory impairment really goes first because that's the one that really is the core feature that you see in your earliest stages. So basically, we're looking at a forgetfulness. And then as the stages go later on, then you're going to see that the person becomes to the point where they actually are unable to function anymore because they can't retrieve any memories on how to do things anymore. So aphasia, apraxia, disorientation, as they get more advanced, you're going to see more of these things happen. And that's why you can see people are not able to talk to you or communicate with you, and they can't take care of themselves. And then you see them in a facility where somebody has to do all the cares for them because they can't feed themselves, they can't dress themselves, they can't toilet themselves. The brain changes, here's where we see the actual physiological changes that you can see. And here we're going to look for these beta amyloid plaques. And these are going to be found outside the neurons. And this is where you see the uh, the the formations that you will show up on a brain scan. The neurofibrillary tangles are inside the neurons because remember the synapses aren't connecting, and so what ends up happening is that they break off. So they're brittle, so they don't connect, and those little pieces all kind of form and complex together. So the neuronal damage can happen in the cerebral cortex, and this leads to decreased brain size. So when you see somebody with Alzheimer's in postmortem, you'll see that the brain is much smaller than the regular person who does not have Alzheimer's disease. Um, so you'll know, but when you lead to this decreased brain size, what also happens is that you also have decrease in the making of acetylcholine. So the enzyme that produces acetylcholine is also decreased. So basically, in a healthy brain, the neurons have long branches, long extensions. But in the person with Alzheimer's, these branches become brittle and they'll break off. So remember, these long branches is where your impulses and all your synapses travel. So if all of those break off, you can see how those synapses are going to get interrupted. Therefore, the information doesn't get translated. And this is where you see the forgetfulness and the inability to remember things. This is where all of that it gets lost because of these little brittle synapses breaking off. So the amyloid plaques are found in the space between the neurons and consistent with abnormal deposits of protein called beta amyloid. These are those little protein fragments, and they break down from an amyloid precursor protein, or what they call APP. So you can see on here, this is just basic pathophysiology. Those long extensions break off, those little extensions clump together or turn against each other, and they end up becoming those little tangles that you see on your scans and x-rays when you take them on the patient's brain. So normally enzymes cut it into fragments of protein. If the enzymes are cut in the wrong spot, then they start cause destruction of the brain. So as you can see there, this is just an interruption of the normal pathway of how these proteins are supposed to work in the brain. So when they are interfered with, obviously this is where you're going to see the brain dysfunction happens, as you can see here in the pictures. So the tangles are found inside the neuron. So we've been talking about outside the neurons where you can basically see the nerve cell. This is now what's happening inside. So the neurofibrillary tangles are abnormal clumps of a protein. The protein is called tau. And you saw tau with another dementia process as well. So that's why we look for certain types of things when we are trying to diagnose our dementias. Okay, so tau you can see normally binds and stabilizes microtubules. However, in Alzheimer's disease, there's a chemical process that happens, and it causes detachment from those microtubules, and so therefore it sticks to other microtubules, and then that's what causes those tangles, quote unquote, that you see in here. So basically, again, we've interfered with the normal process, so things are broken off sooner than they were supposed to, and therefore we run into this problem. So there's the early onset of Alzheimer's disease and there's the late onset. So early onset, of course, is when you see it happening to people getting forgetful in their 30s to their 60s, and then late onset, obviously, is when it happens to people who are over 65. Now, there are several stages of dementia. There are 7 or 8 stages of dementia. However, I will not have you memorize all 7 or 8 stages. I just want you to understand what early onset dementia looks like and what late onset dementia will look like, because the middle part of dementia will look way too close to a mild cognitive impairment, or the MCI. Will also look very similar to delirium, and I don't want you to get those confused. So we're going to just really focus on what are the early stages and how can we recognize that somebody might be having an early stage Alzheimer's dementia, and then the late stages of dementia. So as you can see here, here's the normal, here's the mild cognitive impairment, and here's the Alzheimer's disease on here. You can see, looking at the PET scan on here, how much glucose energy is lost just in the brain scan. Look at all those dark spaces in the Alzheimer's disease. So staging is an artificial construct to help us in the management. So that's why the progression of dementia is really, really difficult. So we're going to focus on early stages, and we're going to just go focus on the late stages. And that's just to help you guys. So here's the warning sign. So I know this is super, super small to see, so I actually wrote it out on the next slide. So you're looking at memory that disrupts the daily life. So yes, it's okay to occasionally forget where you put your keys, but if you're forgetting where you put your keys every single day and multiple times throughout the day of looking for your keys, that's a problem. Challenges in planning or solving problems. So if you're finding that the person's having difficulty problem solving consistently, remember this is a consistent happening and decline of functioning. And that's where we see that. Difficulty completing familiar tasks, and this has to do with eating, dressing, brushing your teeth, simple tasks. Confusion with time or place. Now, every once in a while we get confused to time and place, but now we're looking at a consistency of confusion to time or place. Again, this is consistency and persistency. This is not just, oh, I forgot today, and then they're fine the rest of the week. Trouble understanding visual and spatial relationships, so visual images and spatial relationships. New problems with words, with both speaking and writing. Remember, the elderly tend to have problem with new information and maintaining, but with repetition, they can recall that information. But if you have somebody with Alzheimer's, they won't be able to recall that information, even the multiple times that you keep orienting them again and again and again. So misplacing things, decreased or poor judgment, withdrawal from work or social activities, and changes in the mood and personalities. So these are your 10 early warning signs. So these are things that are happening consistently, and that's what we're looking for. Okay. So when you start with the early warning system, it's really difficult to diagnose because sometimes they're subtle. Because remember, your elderly can cover up forgetfulness. Okay, they can say, "Oh, I just forgot today." But unfortunately, as Alzheimer's progresses, you're not going to be able to cover up. So remember, you want to make sure that you rule out the other causes of dementia, like depression, delirium, and a drug issue. Maybe they got a new medication, or maybe they've been on a different medication. So you want to make sure they're not abusing drugs. And unfortunately, remember from your Gerald lecture last quarter, we do know that the elderly have been known to abuse narcotics, especially cocaine, which is interesting, cocaine, and also they abuse alcohol. So you need to make sure that we are not having alcohol issues, that we are not having cocaine issues and other things that are contributing to the changes in the chemistry of their brain. So our early stages is basically, remember, here's again where that baseline cognitive function comes into play. You need to have a baseline assessment of what is going on with your patient. And then you need to look at the forgetfulness and the loss of ability to complete their normal ADLs. Remember, as the Alzheimer's patient it progresses, they will continue to decline. So maybe they are in the hospital 1 month, and then the next month you have them and they're worse. So that is a decline in the Alzheimer's patient. You may have a relative who has Alzheimer's, and you have watched this progressive decline. So this is what is probably the most frustrating for the nurses and the caregivers, because they are seeing this decline. They know what this person was at baseline, and now they've seen this progressive decline that has happened over months, that's happened over years, and it's just very, very difficult for coping, just not only for the caregivers but for the nurses who watch this as well. So as the client progresses, sometimes they recognize that they are declining, and that can be very anxiety producing for the client as well, especially if it's very frustrating when the nurse has to keep reorienting again and again and again and again. So what we do is our diagnostics is we can do the geriatric depression scale, because we need to make sure that we're not having a person who's depressed, because depression can mimic the signs of Alzheimer's. We can do the mini mental, which we've also talked about, because that's really useful in assessing where their cognitive status is at this moment. We can also do a PET scan. We can do CTs and MRIs, because we can look to see what's going on with that brain activity, how it's working. We could look at and rule out, remember we talked about medications, let's look at our CBCs and our chemistries to make sure that things are doing well. Let's make sure this is not a comorbidity like a thyroid issue that's happening, and we're going to be talking about the thyroid and adrenal later on this quarter as well. And again, here's the EEG. Remember, this is an electric, looking at the brain stem, not the EKG, which is the heart, which we'll be talking about next week. Okay. The pharmacological treatment is that we utilize is actually choline acetyltransferase, or basically we look at acetylcholine. As Alzheimer's disease worsens, remember we see a decreasing acetylcholine. We talked about that earlier. So basically what we're doing is we're supporting acetylcholine. So dysfunction and reduction of acetylcholine are linked to adverse cognitive effects. So that's why that is going to be our treatment of choice. So our drug of choice, now remember, our drug of choice is just basically slowing the process down. Remember, Alzheimer's is a chronic illness, so it's not going to um, cure, quote unquote, this patient. But what we can do is we can slow symptomology. So we can slow the progression. Our drug of choice is Aricept or Diazepam. You probably heard of this drug in your psych class. So this is our drug of choice. You might see them on Exelon or Reminel, but Aricept is our drug of choice. And so basically what you're going to see is an improvement of cognitive function and behavioral symptoms, because we are slowing that acetylcholine destruction. Now, obviously, anytime you give a drug, there's always a side effect. Thankfully, they're very mild. It's all GI related. So nausea, vomiting, diarrhea. Please remember that anytime you give a PO drug, it's not going to work instantaneously. So while you're giving this in the early onset of Alzheimer's, you may not see actual progression, or actually not progression so much as slowing of the progression of the illness, for about a few months. So give it some time. They have to take it for at least a month anyway, so we can get our levels at least up to therapeutic levels. But you probably won't see any therapeutic effect for about 6 months. And it's really, really important that you have them keep taking this drug so that you can see that reduction of the progression of the forgetfulness and stuff as the months go by. There are other drugs you can utilize as well. Memantine is another one, or Namenda. This has a neuroprotective effect because it reduces glutamate. Okay, now glutamate is an excitatory neurotransmitter in your brain. So it blocks the receptors for glutamate. So remember, in Alzheimer's, the glutamate levels lead to overstimulation of the nerve cells. And so when they get overexcited, unfortunately, you can kill them. So basically what this will do is reduce that overstimulation. And so they have seen some success with the memantine, because what they can do is you can again, you don't overstimulate the nerve cells, so therefore you have less cell death happening on there. Okay, SSRIs are your selective serotonin reuptake inhibitors, like Prozac or Paxil. Again, you got in psych, but again, this helps control some of the agitation in your dementia patients. So, and the nice thing about SSRIs is that they are better tolerated than the antipsychotics. So when you have an Alzheimer's patient who is really agitated and can get very aggressive, sometimes SSRIs will help minimize some of those side effects on there. And we'll talk about that in class as well. Now, again, besides giving drugs, let's also focus on what can we do without drugs. So again, we need to look at helping to to compensate for the impairment, because this is a chronic illness. They're going to decline regardless. So the goal is really improve the quality of life. Keep with the patient, keep it so that the patient at least feels like they're in some control of their life, because eventually it's going to get to the point where they're not going to be in control of their life anymore. So cognitive training, you can do cognitive training, cognitive stimulation, training in your ADL. So keep supporting them and doing their ADLs, keep supporting them and doing, you know, their their stuff on there, so that way you keep them as independent as possible. So remember, it needs to be fitted to the family as well as to the patient. This is not a, you know, just a blanket, oh, here, just do this. You have to tailor it towards the patient at all times. So the mild to cognitive decline, you can see here's the 7 stages. We're going to just look at early and late. The middle stages are where we get confused with the other dementias, depression and delirium. So that's why it's really difficult when the person's in kind of a mild to moderate, a mild to mid cognitive decline in Alzheimer's disease, just because it's going to look very, very similar. It's going to look very, very similar to a dementia. However, at this point in time, in the mid stages is where the patient is just alert enough to realize they're going to be a burden to the family, and that could put them at a higher risk for suicide. So you might have to put them actually on suicide risk, because they may say, you know, I don't want to be with this disease. I'm just going to kill myself and leave my family in peace, blah, blah, blah. So this is where you need to start looking at advanced directives with your client and with the family. And you need to think about, okay, if this person stops breathing, do you want me to continue going on with their life? And you need to get a person who is going to be either the power of attorney or the person who's going to be making all the health decisions. And this is where family just gets into sometimes just a disaster, because nobody's been designated as a family person, and there's all sorts of people who want to contribute to be that family person. So this is when you really need to start looking at the advance directive, finding that one person to be the spokesperson for the family. um, this is where you're going to see most of the gapping in the memory and the deficits in the memory start to emerge, is when they're in that middle to the later stages on there. Of course, obviously, when we get to the later stages, this is where you're really going to see the loss of awareness. They're not going to remember. They're going to forget. They don't know who you are. They may know their own name, but they don't know who the family is. They'll need help with doing stuff. They'll need help with getting dressed. They'll need help with their ADLs. Please don't let them drive. They need help with toileting. You're going to see personality changes. They might even wander and get lost. Alzheimer's patients have gotten lost before. So it's really, really important that you um, keep track of where your patients are at this point in time. Okay, of course, in our severe late stages, this is where they really lose ability to respond to the environment, to speak, or to control movement. You might see that, as you saw on the slide before, the person sitting there and you're having to feed them, because you can't really do anything with them because they don't know what they're doing. You might see that this is the place where they they can't even hold their head up. They're bedbound. Um, they can't do anything for themselves. So this is the hard one that's really difficult, just because of the fact that this person is not anything like the person that they were when they first were like this. And this is usually when you have the very late stages where you'll see the person decline to the point where they actually might expire. So, and usually the expiration is because of respiratory involvement, and obviously um, this is when it's the hardest for the family. So the late stages where you have to optimize a person's functioning, this is where you might have to put them in adult daycare, you might have to have support groups. Um, Remember, these people can't make their own choices. Excuse me. So at this point in time, hopefully we've already had a designated spokesperson for the family. You can see here death usually occurs from aspiration pneumonia or other infections. We actually can put Alzheimer's disease patients on hospice. That is something that may need to be brought up to the family, is putting the client in hospice. Remember, hospice doesn't mean that the client's going to die like the next day, People can be in hospice for a year and then get taken off and then get re-put back on hospice. Hospice just gives you extra support. You know, extra. They can even take patients to some of their. And remember, these people are going to be totally bedbound, so they're going to need help if the person has to see a physician. If there's follow-up care, sometimes that hospice can allow for the physician to actually come to the home instead of having to take them to the office. So hospice is just to put a person on hospice doesn't mean okay they're going to die tomorrow. Okay, so palliative care, hospice, two things that may have to be considered for your late stage Alzheimer's patients. Um, Especially when it comes to safety. Remember, we always want to keep our patients safe. So the patient might actually at home need a hospital bed at home. It might even need an alarm because the patient's going to be so confused they're just going to get up, which puts the patient at risk for falling. Remember, it's going to be hard to communicate with this patient. So it makes it really, really difficult not only for you as the nurse in keeping them safe and trying to maintain their cognitive function when really their cognitive function no longer really exists. Um, and sometimes even the medication. Remember, they've been taking these meds all this time to slow the progression. Towards the end, there's really not many medications unless they have a comorbidity that they're going to be taking, if they're even going to take them. Because remember, at this point in time, if they're really lost, they may refuse to take the medication. You might have to slip it into the food if you can get them to eat the food. You know, at this point in time, the patient is really total care. Remember too that not only for you as the nurse, but also for the family. You know, the family, if this patient has to go to an extended care because they can't be at home because there's just a lot of work at home, and they might need to go to a long-term acute care to ease the burden on the family because having a family member and watching them decline is very, very difficult. So you need to support both the family and the patient. You know, you need to encourage visits. You need to encourage the family to have the patient keep reminding him, keep telling him the story, sometimes helping them tell stories. But important, especially at nighttime, is to rest because these people will want to get up. They have no sense of time, so they'll get up and they'll wander. So sometimes the wandering is because they're looking for somebody. So that's why getting everybody in to see them, kind of reassuring them, that's the best you can do, and then trying to keep the client safe. And so sometimes that's why you need to put them in a facility because they have locked doors. They have ways to, put an alarm on the patient so that way if the patient does wander, they can catch them right away. We talked about how before the Alzheimer's brain actually atrophies out, and you can see the healthy brain and the Alzheimer's brain here in this photo. Now, obviously, in dementia, we're going to see a lot of behavioral problems, especially a lot of refusal of stuff. So that's why it's really important that you try to support as much as possible. So we really try not to move them out of their own home, but sometimes it's just not possible, and we have to change the environment for the patient's own safety, and that's when it becomes really, really difficult for both the patient and for the caregivers as well. Sundowning is exactly that. After 9 o'clock, the patient becomes more confused. And sometimes you will see this not only with people who have Alzheimer's, but you will see this in some patients who also have problems with delirium and some other types of dementia. But that's the definition of sundowning. After 9 p.m., it's the patient's more confused. They tend to wander more, and sometimes they're a little bit more combative. So it's really important that you watch your patients and keep them safe when they're sundowning. We don't really know why this happens. Again, sometimes it's not always the Alzheimer's patient who sundowns. You can see this in some of your other patients as well. But that's just a definition of what sundowning is. It doesn't just happen in Alzheimer's patients. It can happen to other patients as well. And a lot of times we see it in our hospital setting that they get more confused if they're elderly, yeah, if they've had a stressful thing happen, just disease process, medication, side effects of medications, the breaking up of the circadian cycle of sleep because we're in there every 2 or every 4 hours, turning the lights on, turning the lights off. It can really promote sundowning. Wandering, of course, is that aimless ambulation that happens with patients. So again, this aimless, purposeless is because they're looking for something, and sometimes you have to recognize that that's what they're looking for. And so, or they're trying to find their own house because this isn't their house. So you basically just keep a safe environment, have alarms, um, walk the patient during the daytime, so that way they are tired at night, and that way they don't wander so much, because if you take them literally out for walks, they get tired, they'll sleep through the night. Again, you have to be careful with physical problems, because it can trigger wandering, and people literally do get lost, and then they'll find them like days later. So you need to really make sure that you are controlled if it's wandering because of an illness versus Alzheimer's, and control the illness. Make sure you've got everything on the illness um, managed. Um, and then sometimes it's people with dementia, and they get outside and then they don't know where they are, and then they'll just wander that way. So wandering is not just Alzheimer's dependent alone. It can be happening because of other things and comorbidities that happen with other illnesses as well. But it does happen in your Alzheimer's patients as well. For the caregiver, remember, caregivers, some of them get paid, some of them do not. So again, um, caregiving, it's really difficult because it puts a burden on the caregiver. And remember, caregivers need to be cared for as well as the patient. So support the caregiver. There's a lot of places that will support caregivers, and actually some monies that can help support caregivers as well. So it's really, really important that you pay attention to the family members and to the actual caregivers, because sometimes they'll get somebody from one of those commercials that you see that will actually be the patient's caregiver, and not even the hospice nurse, but an actual caregiver for them that comes in frequently. So you need to be able that you support that. Informal caregivers basically provide free services, meaning family members. So you'll get a family member, oh, you're a nurse, you can help care for this person with Alzheimer's, and they do. They'll help care for them, but they don't get paid for them. And then you actually have paid caregivers. Regardless, the person who's doing the caregiving to watch someone they love decline is very, very difficult. So support your caregivers as well. Usually there's increased levels of depression and anxiety in the actual family member. That's why it's important that you support your caregivers. There's high rates of insomnia, alcohol use, drug abuse, mortality. So that's why it's really important, especially as you get into the later stages of Alzheimer's, that you are also looking at the whole person, which includes the family. So always include the family and the caregivers as well, because they are also getting stressed. I always try to be as informed as possible to the caregiver, hence the looking at the advance directive, because lack of preparedness can also increase patient stress if they don't know what's going to be happening. So that's why communication, 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 so important in nursing in all aspects of all parts of the disease process. Be a good communicator. Now, there unfortunately are some families who will take advantage of the fact that their family member is confused and try to get stuff from them, mostly money. So, unfortunately, elder abuse does happen, and it's not just physical abuse. Just so that you understand, there are physical abuse that can happen, especially if the patient is wandering. They may actually tie them down, and you'll see um, restraint marks on their arms because they tie them too tight. You might actually see actual physiological wounds. But elder abuse does not stop at physiological. Unfortunately, there is emotional and behavioral abuse as well, and this is where they'll scold them for being forgetful. But elder abuse is still elder abuse. And of course, the other one that you see is the financial abuse, where they try to get the patient's money as being a family member. Now, remember, you can get monies as a caregiver. You can go through your community or through social services, and they can help set you up for that. So you don't need to take your patient's money, but you will see people who will try to do it the incorrect way. So abuse for the elderly happens in multiple facets. It is not just physical. It is not just emotional. There is a financial aspect to it as well. So let's leave Alzheimer's and let's go to something slightly different, but still having to do with the brain and the chemical compounds of the brain. Seizure disorders. Okay, so epilepsy is the fourth most common neurological problem. Only migraine, stroke, and Alzheimer's disease actually occurs more frequently. So what are we looking at? Let's go back to our brain electrophysio and let's just remind ourselves. Remember, brain cells function using rapid electrical impulses. We just talked about how those electrical impulses get interrupted in Alzheimer's disease. So remember that electrical impulses, those are our thoughts and behaviors and perceptions of the world. This motion of the free electrons, sodium and potassium moving across the cell membrane. So these electrical signals help transfer this information from our body through these different synapses. So When you look at epilepsy, we're looking at an interruption or an alteration of those electrical functionings in the brain. And what's happening is it's repeated. We call them a seizure, but that's what a seizure is that alteration in the electrical functioning. So we're looking at multiple alterations in that electrical functioning. So what causes epilepsy? The four most common are head trauma, stroke, brain tumors, and brain infection. Other causes, of course, you can see here are drugs. Some of it is genetic, some of it you have malformations in the brain. And then you can see there a majority of these other ones are actually 60 to 70%. It's really unknown. In other words, it's idiopathic, meaning it just happens and we don't know why it does. Okay, but really, um, head trauma, stroke, brain tumor, and brain infection are your epilepsy causes. So what does that mean? Well, let's first of all define our terms. Seizure is a single event. So you have an abnormal electrical discharge, it interrupts the electrical pattern, and that is what we call a seizure. Epilepsy is this chronic disorder of a seizure. So you have the chronic seizures, recurrent seizures happening, which is basically continuous interruptions of electrical impulses. So at least two unprovoked or reflex seizures occurring greater in 24 hours apart. And then status epilepticus is the disease, we call it the disease process of having epilepsy where a seizure lasts a super long time. And this is where you'll see seizures lasting for 5 minutes or longer. Some seizures can actually last for 30 minutes or longer, and there's no recovery in between. So we've seen patients have seizures maybe for 5 minutes, they'll recover, and then maybe in 30 minutes they'll have another seizure for 5 to 10 minutes. We call them at that person at that point in time to have status epilepticus. So seizures really is going to depend on the type of seizure. Generalized seizure, basically, they actually have a loss of consciousness. Usually it affects both sides of the brain and the cells on both sides of the brain at the same time. And there's different types of seizures. Can have grand mal seizures. You can have tonic-clonic seizures. You can have petit mal seizures. So there's different types of seizures as well as that. But the generalized one is where they actually lose consciousness. You have a hard time waking them up while they're having their seizure, and it's both sides of the brain. Focal seizures means it's only one side of the brain or a group of cells on one side of the brain. And focal seizures, you will see only one part of the brain, so you might see a hand twitching or something, and we'll talk about that in just a little bit. So your textbook talks about the different types of seizures, the absent seizures, the myoclonic, the tonic-clonic. Um, Really, when we start looking at it, we'll try to describe if a person goes into a seizure in your questions. And we basically will kind of tell you what kind of seizure they're having, like a generalized seizure. What's more important is what you do during the seizure. That is what's more important, to recognize the seizure and then what do you do during the seizure. Because the thing you have to focus on is keeping the client safe. Okay, because during a seizure, everything basically freezes up, which means they're not going to be breathing. So the fact that they're not opening their eyes and looking at you, the more important thing is that their chest isn't moving and they're not getting air in. That's why you'll see people sometimes hitting the patient on the chest in the seizure saying, breathe, breathe, because they want them to take a breath. And after the seizure, because basically everything has taken on a big electrical impulse whack, they might have a headache, they might be sore in their muscles because everything's been so tightly held and tense. They might be really sleepy, which is really common, where they just get really sleepy, and sometimes they actually are a little confused. It's like, oh, what just happened? People do not remember having a seizure. They might remember what happened right before, where they'll say, oh, I see lights happening, I see an aura, I smell something funny, and then they won't remember the seizure. Then after the seizure, they'll say, oh, what just happened, and why am I so sore, and I'm really tired, and leave me alone. Textbook, focal seizures are basically on one side. So you might see an impairment of consciousness or awareness, and then the symptoms may progress to actually a generalized seizure. But the focal one, sometimes you only see like a hand moving, and sometimes they might look at you and they still might be able to answer you, but then they don't remember what you asked them. Phases of the seizure activity, like I said, there's the beginning. So this is when it's hard to describe how the aura feels, but they may feel funny, feeling of deja vu. Sometimes they're a little nauseated. Sometimes the hand twitches, and then they'll go into a seizure. The middle is the most active phase, and this is where it usually lasts. Some seizures are very short. Sometimes they're a minute, and then they'll go away. Sometimes they're longer. And like I said, if they're over 5 minutes, you need to call and let the doctor know because they're probably having, um, obviously, a more significant seizure. And then, of course, is when the seizure stops. That's what we call the post-ictal or the end of the seizure. So you have the aura, the ictal, which is the middle of the seizure, and then the post-ictal. So your priority is maintaining that patient's safety during that whole part of the seizure and recognize, hey, they've gone into a seizure and I need to do something about that. Always, always, always support the airway and the oxygen. Turn them to their side. Note when the seizure starts and note when it ends. It's really important that you note the beginning and the ending. That's why you have to recognize when the seizure starts. Sometimes they'll tell you, I feel funny, and that you should just cue up on that if you know they have history of seizures. Okay? We always, 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 if they're going into a seizure, we do have a drug of choice for that. Our drug of choice, if they go into a seizure, is always Ativan. Now, you need to give the Ativan while they're having the seizure. It does no good to give the Ativan after the seizure because you need to interrupt that electrical stimulus. And that's basically what the benzodiazepine does. It helps suppress that electrical activity, that over electrical activity going on in the brain. And then that will help, the seizure to kind of end, so to speak. So after the seizure, you need to physiologically support them, psychologically support them, because remember, they're going to be confused, they're going to be very anxious. They may have even gotten incontinent in their seizure. That happens as well, and so they'll be very embarrassed. So our drug of choice is always Ativan lorazepam. You give it IV push. That is drug of choice. It is a benzodiazepine, so you need to make sure they're not allergic to it. But after the seizure, after they come back, always make sure that they're safe. They haven't bitten their tongue or haven't bitten through a lip. That's why they tell you, there's a tongue blade you're supposed to insert so they don't clamp down. By the time they start the seizure, that tongue blade, there's no way you're going to insert in there because their teeth are clenched together. And please don't put your fingers in there because they're going to bite your finger off. Okay, so obviously, if these people have problems with epilepsy or things like that, they need to have some sort of medical alert bracelet so we know what's going on with them. We need to make sure that they don't do things by themselves. We need to make sure that they don't get overstimulated. So caffeine shouldn't be part of their drinks because that just causes more stimulation. We don't need that. There's a wonderful commercial on here, and it's actually a guy who goes into a tonic-clonic seizure, and then there's another one where they show a petit mal seizure or an absent seizure, and what you see is somebody, they just literally kind of blank out, and then they come right back, and they've had an absent seizure that way. And again, there's different medications that affect those. You will get more of those when you get into critical care. Now remember, we said our drug of choice is the benzo during an active seizure. But what can we do to prevent seizures? So when you have somebody who is epileptic, they will be on several kinds of different types of drugs. The old school drug that we used all the time was dilantin or phenytoin, we used for tonic clonic seizures. The only problem with using this drug is that it has a very narrow therapeutic index, meaning like digoxin, you can hit a toxic level really, really quickly. So this drug, because it has a narrow therapeutic index, you actually need to monitor for levels of toxicity. So you need to draw levels of dilantin before you give dilantin, or if you're starting dilantin, they will always, always, always do a level. And then they will continue to monitor those levels because of that narrow therapeutic index, because you can reach a toxicity level really quick. So while dilantin was used a long, long time ago and we still utilize it, there are better drugs that are newer and much easier on the body. One of them is lamotrigine or Lamictal. And Lamictal helps suppress neuronal firing. And we kind of use that now more for your epilepsy patients than I see used dilantin. But that's because it's a newer drug and we've done more studies on it and it's done better. Phenobarb is a barbiturate, and this is used for generalized seizures, and this also helps suppress that electrical firing. But again, because it is a barbiturate, it can be very habit forming. So as you can see on here, that's not really our kind of thing. So topiramate or Topamax, this enhances GABA action, and as you remember, going back to some of your psychotropic drugs, we talked about several of your neurotransmitters, GABA, the sodium channels, those kinds of things on there. So you'll see that some of these drugs are actually very similar on here. You might see valproate here as well, which is Depakote or Depakine. You might see Tegretol, which is carbamazepine. So you'll notice that some of these drugs are very, very similar. The important point that you have is regardless of whatever drug that they are taking to help with their epilepsy, that you understand how the drug works and that you understand what to look for as a side effect of the drug. So for example, the Dilantin especially, we need to monitor for that narrow therapeutic index and get the levels on there. We know that it is utilized for preventing seizures, so um, we need to make sure that they aren't having breakthrough seizures while they're on this drug. Majority of these drugs also can't be used while um, they are pregnant. And so you need to find drugs that will work for people who are pregnant. They need to take their medications at the same time every day so that we maintain a consistent level of the drug in the body, because that's how the drug works. So when you are looking at medications, just like any other medication that you take and any other medication that you've had for any other disease process, take it at the same time, monitor for the side effects, and then if there's levels that have to be drawn, make sure that the levels are drawn. And make sure that the patient understands why they were taking the drug and what it's doing to help their disease process. So general nursing considerations and medication considerations basically for any disease process we study this quarter. Dilantin. One of the biggest side effects of Dilantin, and only for Dilantin, is gingival hyperplasia. So you'll see their gums start to overgrow. And this is only for Dilantin. So one of the biggest side effects you need to watch out for is good oral care so they don't get that gingival hyperplasia. You notice that it causes a lot of other side effects on there, but the most common one that usually you will see is that gingival hyperplasia. So the dizziness, the vertigo, of course, it's working on the electrical stimulus of the brain. But you need to make sure that we um, really watch and do good oral care. And again, because of, I can't say it enough times, because of the narrow therapeutic index, watch for the toxicity level and do frequent monitoring. Focal seizures. Dilantin is still the most effective we have for focal seizures, which is the one side of the brain. So here's where you see some of the other drugs that also were helpful. Tegretol decreases the nerve impulses that cause pain. So it's equally as effective. So you might see them on Tegretol or Dilantin. We talked about nerve pain. So here's where you see Lyrica. Lyrica has been used for restless leg syndrome, which you see on the commercials. So has Neurontin. Neurontin, look at the first part of that word, neuro. That means nerve. So gabapentin, Neurontin, you may have seen in your hospital setting for other things besides focal seizures, but it will work well on focal seizures. Keppra. Keppra is another one that's been very useful in managing seizures. So that's why we're getting away from the Dilantin because of that narrow therapeutic index. We're moving to other drugs like Keppra, like Lamictal, like some of the other ones that we've discussed on here. Just because their safety index is much better, and they're newer drugs, which of course then increases their safety as well as we come out with more studies and better ways to manage disease processes. So when you are handing off, you need to look at, okay, do you understand what a seizure, what causes it? Is it genetic? Is it hypoglycemic? Is it they've had a head injury? Okay. What is the seizure trigger? Is there something that will do it? Is it lights? That's why blinking lights. Sometimes people who are epileptic, they shouldn't be when the fire alarms go off. You know how the fire light blinks. Sometimes that will actually trigger a seizure in some of your epileptic patients. That's why they tell you all the time, if you see the fire lights going on, if you have epilepsy, look away or close your eyes or go into a room where you don't see the lights flashing, because sometimes that will trigger a seizure. So what is the seizure triggers? That's important for you to understand as nurses. Education cannot be said enough times. You need to look at not only epilepsy, but your triggers and then your complications and then safety. Okay, so that's why, you shouldn't swim alone if you have epilepsy because you don't know when you're going to have a seizure or you could drown. So those are the things. So, and a third of the people who have epilepsy also experience depression and anxiety. So it's really important that you look at that and focus on that as well. So multiple things. And then remember, after they've had their seizure, Remember, some of them are also a little confused. So safety, 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 education, education, education. Just cannot stress it enough for all of the people who have problems with seizures or epilepsy in particular. Status epilepticus, a disease process. Remember, we are here to help each other. Um, and so please remember, if you have questions, we'll be talking about this in class. Asking questions is never an issue. We'll be going over some examples. We'll also look at the video again. Thank you for taking the time to listen to me. I will see you in class.